So we're going to talk now about some specific diagnostic tests for infertility. Specific diagnostic tests for infertility. So I would look over these and just have a general idea of what each test does. What does this test do? What does it look for? For example, hysterosalpingogram is a female. Test for a female. And it assesses tubal patency. What they do is they shoot dye up through the vagina and they follow, and then they x-ray to follow the path of the dye. It should go up through the vagina, into the cervix, through the uterus, and up through the fallopian tube. So if there's a blockage from scar tissue or something, then that dye is not going to travel, and it's going to tell them about the path. You know, it follows the path that sperm would follow, and so it will tell you about the capacity for patency in the fallopian tubes. STI workup. We did for both sexes, male and female. Are there any untreated STIs that either one have? Because the big thing that we think about when we think about STIs are infections and subsequent scar tissue from it. Of course, we don't want anybody to have an untreated STI. We want everybody to have everything that they would have treated for pregnancy, but we would work them up for any possible STIs. For a female, serum progesterone levels. And this test is just a serum test that looks for the level of progesterone. Progesterone is required for a pregnancy to implant in the uterus. So there are women who actually, the egg and the sperm will meet and they'll unite. And then what happens is, and we'll talk about this in the next chapter, but after that sperm and egg unite in the fallopian tube, they travel together as the cells are reproducing, travels down to the uterus and it implants in the uterine wall. That pregnancy is not viable until it gets into the uterine wall and implants. And low progesterone levels will keep it from implanting. So what will happen is you'll have a conception, and then the woman will not have a period, and then she won't, it won't implant, and then she'll have a period that's late, and she may never even know she's pregnant. She doesn't have a period that's a week or two late. She actually was pregnant, but the pregnancy would not implant in the uterus, and so she has a period and it all sheds away. A lot of times she never knew she was pregnant. And that's from low serum progesterone levels. Assessment of cervical mucus, assessment of vaginal pH. We want the environment to be as hospitable as possible to sperm. So if the cervical mucus is not very thin and watery, then if it's too thick and tenacious, then sperm can't get through it. Also, if the pH is off and if it's too acidic, it's too much for that sperm to overcome. And, remember, I told you that the prostate releases some fluid into the semen that helps counterbalance that acidity. But if it's too much, obviously it's too much. So that's something else we would look at. Basal body temperature. When a woman ovulates, the temperature dips at ovulation and then spikes after. And you can look in your textbook if you want more information on that. But so we can have a woman check her basal body temperature every day. Remember, I said you have to take it the moment you open your eyes, before you get out of bed, go to the bathroom, or even roll over for it to be accurate, so you can tell when it drops and then spikes. And that helps predict ovulation. Ovulation predictor kits, just that you can buy over the counter, help predict hormone levels, and those are fairly reliable. Semen analysis for the male, we'll talk about that again in just a minute, but that is we get a collected specimen of semen and evaluate it in many different categories. Sperm penetration assay in a male, obviously, the sperm may be okay, but they lack an ability to penetrate the egg. There's a special substance that allows them to penetrate an egg. The minute that egg is penetrated by one sperm, it cannot be penetrated by any other sperm. So the minute the sperm goes into the egg, it's like a big wall goes around it, and no other sperm can get near it. And so we do a sperm penetration assay to make sure that's functional. And then what's something we call clomiphene challenge. Clomiphene is a medication, also known as Clomid, and it helps induce ovulation for patients who are not ovulating. There are great big gun fertility drugs that we can use. This is one of the small drugs that we use to just help, induce ovulation in women that are ovulating regularly. Okay, semen analysis, just to kind of talk a little further about what was on the previous page there. When we get a semen analysis, the sperm pH should be at least 7.2 or higher. Sperm Sperm motility, at least 40% of the sperm should be forward moving with adequate motility. In other words, are they good swimmers? If they're not good swimmers, they're not going to survive. Sperm volume should be a minimum, the total sample of the ejaculate should be 3 to 5 ml. Average, it should be at least 1.5 ml, with the average being 3 to 5 ml. The sperm density, there should be at least 15 million sperm in every ml of the sample. So the sperm count should be greater than 40 million for the total sample. There should be at least 40 million sperm in the sample. They look for liquefaction time of the ejaculate, and all of that is listed in your textbook as well. So those are just things that they look at in the sperm. I have always been taught that when we collect the semen analysis, it has to be fresh, meaning not something you can refrigerate or collect today, take in tomorrow. It has to be taken in immediately. Someone last semester, and I haven't followed up on this, but someone last semester had a significant other had done this recently and said that had changed now, and they had so many hours to get it there. So again, I haven't verified that. It has to be collected within, in a few minutes.
I used to work in the lab, and it used to be within, I believe, 2 hours from the time it leaves to the time we have under a microscope.
From the time you have it under a microscope, so really, that 2 hours. So it really needs to be less than that by the time it's collected by the lab and processed.
Yep.
So yeah, my understanding was under an hour to get it to the lab, to hear your specimen. So I don't know if that's still the case.
Yeah.
A student told me that, so I don't know how reliable that is. But the bottom line is, a lot of times it is collected on site, in a room, and then they give it to the lab personnel. But especially if you live a ways away, it's not going to be okay to collect it and stick it in the fridge and then drive it in. It's not going to be any good. Thank you for clarifying that.
It's been a while since I was there, but it's still possibly changed.
And I'll try to check on that. That's just something a student had told me. Okay, so let's talk a little bit about the male and something that might affect fertility, erectile dysfunction. So there are a couple different types of erectile dysfunction. The definition of erectile dysfunction is the inability to achieve and maintain an erection. That's the definition. The inability to achieve and maintain an erection. So we think of this being a problem of an older male, and very often it is. But there are some things this could affect a younger male as well. There are 2 types, and you do need to be able to identify these and understand what these are. Number 1, organic. Organic means it comes from an identifiable medical cause. What do you think is the most common cause of organic erectile dysfunction? What disease process? Diabetes, number 1. Heart disease probably is number 2, but diabetes is definitely number 1 because diabetes affects the circulation, right? So it affects the circulation in that part of the body as well. So diabetes is number 1. Organic erectile dysfunction is caused by an identifiable medical disorder, heart disease, sickle cell disease, diabetes, anything that affects circulation and impedes circulation in the vessels in the penis as well. And then if it's functional, on the other hand, erectile dysfunction, this can affect someone of any age. Now, if you're diabetic, you could be a type 1 diabetic and have erectile dysfunction at 35. It's entirely possible if you've been diabetic for many years. Functional, again, is related to a history of trauma, abuse, anxiety, depression, or any kind of related psychological process. So, in this case, the individual is probably going to need significant therapy to regain function. So, which do you think is the harder one to treat? Organic or functional?
Functional.
Yeah, absolutely. We have medications, we know a lot about diabetes, there are things we can do, but functional, depending on what caused it. Let's say if the individual is a victim of sexual trauma, if they've had some kind of traumatic experience, if they are severely depressed, that's going to be really hard to treat. So we need to look at the individual and determine first, is it functional, is it organic, and then treat it from there. So medical management, we have a specific class of medications that are vasodilators. You've probably all seen these commercials on TV for Viagra, Levitra, Cialis, all those drugs, and those are the brand names. I don't have the generic names here, but those are all the brand names. And what these drugs do is they cause systemic vasodilation, so therefore they help those vessels in the penis as well as other parts of the body to dilate, restoring function. So these medical class of vasodilators, will they treat organic? Will they treat this type, organic?
Yes.
Will they treat functional? No. If your problem is not a circulatory problem, taking Viagra or Levitra is not going to help. If you can't get an erection because of your history of sexual abuse, giving you Levitra is not going to do anything, right? Because it's not a you don't have a physical cause. Only with a physical cause is the medication going to be effective. So these medications are only for organic erectile dysfunction, not for function. So, funny story that I always tell you guys. Years ago, when Viagra was first being, years ago, I guess Viagra is probably at least 20 years old by now. Viagra was first being tested as a cardiac drug. It's a Pfizer drug. And Pfizer was testing it for cardiac patients for systemic vasodilation to help perfuse the heart. And so it was just entering human trials, and they were giving it to cardiac patients. And so as they were, bringing these people in that are going through trials, these men started telling them, I don't know what, this looks like in my heart, but let me tell you what's working that hasn't been working. And literally, they didn't take long for them to make the connection that this is the gold mine, because before this, there were no drugs for erectile dysfunction. There was nothing. Or a penile implant was about all we had to offer. So now we have this medication that works quite effectively for organic erectile dysfunction, and it wasn't even what it was supposed to be for, but they quickly got it approved for that, and now Viagra's a household name. Everybody knows what Viagra is. You can't say that word without everybody knowing exactly what it's for. And those of you guys who maybe work at Memorial now may see, have any of you seen Viagra used on the units you work in for your cardiac patients? I've had several students who work over there tell me that they're using it again in the vascular units for cardiac, function to vasodilate and help perfuse the heart. So this drug is, got a, very, very widely and well known. Some things that you need to know about Viagra. Yeah. Some things we need to know about Viagra and other erectile dysfunction drugs are that number one, it's contraindicated for patients who are on nitrates. Why do you think that is? What's a nitrate? It's a vasodilator. So now we got a nitrate vasodilator. Now we're giving them Viagra vasodilator. So now we're giving them two vasodilators. So what's going to happen to them? What's going to happen to the blood pressure? We're going to pass out on us because we're giving them two very potent vasodilators. If they're on any kind of nitrate that's already a vasodilator, this is contraindicated for them. We need to teach the patient to watch for signs and symptoms of sudden hypotension, fainting, dizziness, orthostatic hypotension. So we have to really be careful with patients that are on antihypertensives because we don't want the sudden highs and lows. So patients need to watch their blood pressure very cautiously. If they start feeling not even nausea or vomiting can be a symptom of hypotension, dizziness, anything like that. We want to warn them about that. Also, watch for signs and symptoms of priapism. Who knows what priapism is? Anybody know what that is?
It's an erection longer than like 4 hours.
On TV, the dreaded, regular, seek medical treatment if you have an erection that lasts longer than 4 hours. That's priapism. And that priapism can be life-threatening. Because what happens is you get blood into the penis that you can't get back out of the penis, and if you don't get it back up quickly, you start getting tissue ischemia and tissue death, necrosis of the penis. We're talking about possibly losing your penis if you don't get that corrected quickly. So autism is a medical emergency. A lot of times, they can give the patient some medications and relax them, and it'll go away. Warm enema even, because what we're trying to do is we're trying to dilate the vessels again. Get blood in there, you can't get it back out. So we're trying to redilate the vessels so that the blood comes back out of the penis and the erection goes away. Because if we don't get that fixed again, it's literally there's blood in the penis that's trapped there and you can't get back out.
Isn't it compartment syndrome?
Well, You could call it compartment syndrome. It is, technically speaking, it's not like an extremity, so, but it's the same effect. It's the net same effect. Yeah. It's the same thing as compartment syndrome, really. And, again, the worst case scenario is ischemia and tissue death. So also we want to make sure that we teach patients that more is not better. If, we all think if one's good, two must be better. Three must be even better. And you can't get any better than normal function. So if you're a young, healthy, normal male with normal sexual function, taking Viagra or Levitra or Cialis is not going to make your sexual escapades any better. If you have normal function, you have normal function. The only thing that you may do by taking something like this is give yourself a case of priapism. It will not improve your erection or anything like that. So that is something we need to make sure we teach patients, that this is not going to make you Superman by any means. It's only going to bring you back up to normal if you're not normal. So that's a really important patient teaching thing, because we don't want to see young healthy men in the ER because they took 3 Viagra of your Puffles Viagra to see what would happen. Okay, so now, and we talked about some of this, but just a few more suggestions. So with people with infertility issues, some non-invasive, we should probably back to that other set of slides, some non-invasive medical things that can be suggested to enhance fertility. So for a male, eliminate wearing briefs. So what is it about wearing briefs versus boxers that's going to be important? What do we talk about? Body temperature. So if you push the testicles back close to the body by wearing briefs, you're going to raise the temperature in the scrotal sac, right? And possibly kill sperm. So one of the first things we tell men, stop wearing briefs, wear boxers. Stay out of the bathtub and hot tub. Because again, a quick bath probably doesn't hurt anybody, but for men who love to, they love to get in the hot tub or take a hot bath because you have muscle aches or whatever, that is apt to lower your sperm count. Anything, again, that compresses the testes up against the body, like bike riding, horseback riding, any activity that holds the testes close to the body. Use water-soluble lubricants only, because you need to check also the bottle and make sure they do not have a spermicide in it. There are some lubricants that have spermicides in it. So you want to make sure you check that and make sure you're not using something that's actually killing sperm. For women, position after intercourse so that sperm can remain in the body as long as possible. Sometimes we'll tell women to not get up after intercourse for at least an hour, or tilt your hips upwards. Anything that will keep as many sperm in the body as we possibly can. The more you lose, the less you have that can travel up to find that egg. Use basal body temperature charts, ovulation predictor kits, and learn your own body's clues. So that menstrual chart that we talked about before when I was over on the board, that's going to be really important in learning what your own body does. Knowing your body is the best thing that you can do to help determine that ovulation is coming. For both, eliminate alcohol, eliminate tobacco, eliminate other substances, any kind of street drugs, anything like that from the body, eliminate stress. Maintain your BMI between 17 and 27 for both male and female. And for the female, if your BMI goes above 27 or goes below 17, you are at risk of not ovulating. So, what do you think happens if your BMI is below 17? Why do you stop ovulating? Because you do. Do you have any idea why? Well, it is exactly. For women who run marathons, a lot of times they'll stop having menstrual periods. And the reason is they stop ovulating. So let's think about it. What hormone is controlling ovulation? Estrogen, yes. Where is estrogen stored in the female body? In your fat cells. In your fat cells. So if you have anorexia nervosa, or you run marathons, and you're very, very thin, and your BMI drops to 15, you have very little fat cells, very little estrogen, you're going to stop ovulating. On the other hand, if you're very obese and you gain weight and you weigh 375 pounds, then your estrogen levels, even though they're not low, they go awry because you have a lot of fat cells, it still will affect ovulation because the estrogen levels become abnormal. So too much body fat, not enough body fat, either way will affect ovulation. Okay, so let's talk about pharmacological options now. So I talked about a couple of these meds already, but Things that we use to help enhance fertility. Clomiphene or Clomid that I talked about a minute ago. In a female, it's used to induce ovulation. It's not considered one of those big fertility drugs, but it is used a lot of times for females to help induce ovulation, and it causes about a 10% risk of twins. That's all. That's all we're dealing with Clomid. So that was not too bad. So any woman who uses Clomid has a 10% risk of having twins. We can use Clomid in the male as well, and in the male, Clomid is used to increase testosterone levels. It's not approved by the FDA for that. It's an off-label use, but it will for men who have hormonal deficiencies. That would be hypogonadism on that chart. It would increase the levels of testosterone in the male body if that's necessary. And then we have ovulation-inducing drugs, which are in a whole large class. And I'm not going to go through all the names of them, but the most common one that we think of is a drug called Pergonal. These drugs all work alike. They hyperstimulate the ovaries to release bunches of eggs at once. So these are the drugs we use for IVF and things like that. We're trying to get the uterus to release as many eggs as possible. So in a normal month, the uterus releases just one egg, right? Occasionally, on a rare occasion, it might release two, but typically it releases one. So if we give these Pergonal or these big old guns that are considered fertility drugs, it causes as many as 8, 10, 12 eggs to be released. It hyperstimulates the ovaries. And that has a whole set of problems that go along with it, with hyperstimulating those ovaries. Most women are willing to do it because they want babies so badly, but if we increase your hormone levels that much, like these drugs do, it causes wild mood swings, crying spells, emotional issues. It also increases the risk of ovarian cancer. We're putting the ovaries on overdrive. That's what we're doing. So we're trying to get the ovaries to release a bunch of eggs. And so it puts them on overdrive and will increase the risk of ovarian cancer. Progesterone, I talked about already. For patients, for women who have low progesterone levels, we supplement them in early pregnancy to prevent recurrent miscarriages that have been caused by low progesterone. A lot of these miscarriages have never been diagnosed. Like I said, the egg and the sperm will unite and meet, but they won't implant in the uterus because the progesterone levels are too low, and the pregnancy just washes out of the body with a late menstrual period. And the woman just thinks she's late and never knows that she's actually pregnant usually. And then there's a disease called PCOS, polycystic ovarian syndrome, the female, of course, that causes, it's a syndrome, and it causes lack of ovulation. Women don't ovulate. It also causes them to have very high blood sugars and insulin resistance. So we treat them, if we can get their blood sugar down and their insulin levels back to normal, we can help restore ovulation. So they treat them with an oral anti-diabetic agent. So for people who have PCOS, polycystic ovarian syndrome, they do not ovulate and they have very high blood sugars and insulin resistance. So we have to treat that, and then hopefully ovulation will return. And then, if not often is surgery an option, but surgery can be an option at some times. For example, the varicocele that I told you about. That's a surgical option, easily fixed. Or if there's a damaged fallopian tube or scarring, we can go in and try to get rid of that scarring. But what happens when you go in the body to try to remove scarring?
Create more scarring.
You create more scarring. So every time you go in there, you get more adhesions, more scarring. So it has to be a pretty extreme case for it to be worth trying to go in there because you're just going to create more of the same problem you're trying to fix. So if the problem is a scarred fallopian tube, they really have to think hard about going in there to fix it. Because the odds are you're going to create more scar tissue. And then, now let's talk about if spontaneous pregnancy is not going to happen. Whatever the problem is, it's clear that a spontaneous pregnancy is not going to occur. Then options that a woman and a man have are in vitro fertilization, surrogacy, adoption, donor sperm, donor eggs, artificial insemination. Those are our options. First thing a couple has to do is they have to grieve that loss of that genetic link or the normal pregnancy that they expected to have. So if you have in vitro, it may be your own sperm, your own sperm and egg, but it's not going to be a spontaneous pregnancy. If you do adoption, surrogacy, donor sperm, or donor eggs, one or other of the couple is not going to be their child. maybe both. So you have to grieve the fact that that's not going to be your genetic material. So, there's a lot to that. There's a lot of ethical issues here we're going to talk about. It gets really muddy, when you start talking about these things. It seems like medical advances have outpaced our ability to deal with the medical advances. For example, you do surrogacy, which means you hire a woman to carry, a baby for you. There's all kinds of ethical things that go along with that. We really haven't ironed it all out yet, how it all works out. In some cases it works out well, in some cases it doesn't. So we're going to talk about some of that. Okay, some ethical issues, as I said, that we're going to talk about. First of all, with fertility drugs, you have a risk of multiple gestation. So we have to think about what's the ethics of that. You may think, well, what's wrong with multiple gestation? Okay, so when I say multiple gestation, I don't mean twins, I mean 5, 6, or 7 babies with in vitro. So what are the ethical issues for having 5, 6, or 7 babies at once? It's dangerous for the mom, very dangerous to carry that many babies. What else? What else? You think it's dangerous for the baby? Because what's going to happen to them? What kind of, are they going to be premature when they're born? Yeah, you can't, a woman can't carry 7 babies to term, or 6 or 5 or 4. It's impossible. Your uterus is not made for that. So those babies are going to be very, very extremely premature. I would say if you had 6 babies in the NICU, the bill could reach $1 million like that.
Could there be a risk for something to be wrong with the baby?
Sure, absolutely. That many babies, I mean, the best case scenario is like TLC, John and Kate plus 8, they had 6 kids. She had sex couplets, and they're all healthy. They're all teenagers now. That is a rarity. What you see on TV there is not what usually happens. I personally have seen quads twice. Seen several sets of triplets, probably dozens of triplets, maybe not that many. But I've seen 2 sets of quads in all the years I worked. One turned out pretty good. One baby had a few issues, but the other 3 did fairly well. They all had some issues of prematurity, but they were going to do reasonably well. One was a catastrophe. All the babies died in utero but one. And then the one that lived had extreme cerebral palsy, lived to be a teenager, and then I just happened to know that she died. She died. And it was just a catastrophe. So, it doesn't always turn out like you see on TV. Or octomom or octuplets that are all okay. That is just, I can't even tell you how rare that is for them to all do okay. I really can't even explain it. Because usually there's so little when they're born, they have so many issues. So prematurity is a huge issue. So there's definitely an ethical dilemma there. And so you're asking $1 million, you're going to have $1 million bill. Who's going to pay that? Well, your insurance. Well, what's that going to do to everybody else's insurance if we all did that? What would happen to our insurance? We wouldn't have any more insurance. If we all had 6 babies and we all had $1 million NICU bills, insurance companies would go broke. Thank goodness it doesn't happen very often. And then, so if you have had in vitro fertilization, you end up with 6 babies, 7 babies. What the doctor, you've worked and paid thousands of dollars for that procedure. We're going to talk about the procedure in a minute. And then they find out that 6 have actually taken, and you've got 6 babies growing. A lot of times they'll say to you, well, it's really dangerous to have 6 babies. We'd like to reduce it to 2. That means we'd like to abort 4 of your babies. And then you, as the mom and dad, have to decide, do you want to do that? You've spent $25,000 trying to get pregnant, and now they're asking you to abort 4 babies, so 2 of them might survive. What a question to ask. I mean, as a parent, to ask, would you kill 4 of your babies so 2 of them might survive? How can you make that? What a decision to make. And everybody has their own feelings about terminating pregnancies, and I'm not going there, but I'm just saying what an ethical dilemma that is to deal with. If you have 6 that are apt not to do well, but you might be able to have 2 that do well if you terminate 4 of them. Hard question. Obtaining donor sperm and donor egg. So if, let's say, you waited you're a female and you waited way too long, you wanted to have a career, you waited till you were in your mid-40s
to have a baby, and it turns out you went into early menopause. You don't have any eggs, so you can't have a baby. You have no more eggs left because you went into menopause very early. So you have to have a surrogate, and your husband or significant other has to use an egg from the surrogate or a donor egg from somewhere, and so that's not going to be your baby, but it's going to be his baby. Or let's say you marry an older man who's had a vasectomy, and you want more kids, but he's had a vasectomy. So you as a female have to get a donor sperm from a sperm bank to have a baby. So it's now sperm bank baby, not his baby. Decision whether to tell the family about donor genetic material. So you do that. You tell your family that we don't know who's the father of the baby is, or do you not tell them? And then what about the child? Does he, need to know what medical issues he may have? Are there medical issues that run in that family? How do you find that out? If it's from a sperm bank or whoever the donor material is, how do you find out what family history they have? What he may need to know about his family health records? Using surrogacy with risks of surrogate mother keeping the baby if it's her biological child. So again, a surrogate can be a variety of combinations. I don't know how many of you all know that, if you know who Keith Urban and Nicole Kidman are, who had both their children by surrogates because she's older. I think she's close to my age. And so they had 2 children by surrogate. It was his baby. Now, whether or not it was her baby, I'm not sure. She was older. But anyway, they had successful pregnancies with surrogates. But if you don't have eggs anymore, then it may have to be your husband's sperm, but the donor's egg, the surrogate's egg. In that case, that technically is her biological child. Not yours, but hers. So while legally the paperwork may say it's your child, but at birth, if she has that baby and she decides she wants to keep it, the courts are much more likely to rule in her favor because it is her biological child. If, on the other hand, you want to do a surrogacy and you couldn't get pregnant, but you have eggs, so you donate your egg, he donates his egg, and then we take that embryo and we put it in another woman. So another woman is basically just a gestational carrier. She has no biological claim to the pregnancy. That's much likely to end up in your favor in a legal situation because that's not her baby. She's carrying a baby that doesn't belong to her. She's just the warmer. He's just the genetic carrier. She is not not genetic carrier, gestational carrier. She's not doesn't have a genetic connection to that baby. So that one's likely to go in favor, if she would want to keep the baby, of the biologic mother, not to her. So you see where this gets so muddy. What to do with frozen embryos? So what happens in in vitro fertilization is this. We hyperstimulate a woman's ovary so that it releases multiple eggs. Lots of eggs, the more the better. And then let's say it released 10 eggs, which is a lot. And so we take those 10 eggs and they take them to they collect them in a fertility clinic, take them to the lab, and they mix those eggs with sperm from whoever, father, significant other, whoever you want it to be. So you mix the eggs and you mix the sperm, and of those 10, let's say 6 of them take. 4 of them die in the petri dish, and 6 of them survive. So you have 6 embryos right there. So let's say we implant 4 in the mother. We put 4 back in her uterus, hope that 4 of them take and grow. And of that 4, the reason they put so many in is because so many of them die. It's an expensive procedure, $25,000 a crack every time you do it. So you want to put in as many embryos as possible, hoping that at least one will survive. You don't want to just put in 1 because the odds are some of them are going to die. So you put 4 in, hoping 1 survives, at least 2. So you take those 2 and you put them in a freezer, hoping that maybe a couple years later, maybe you'll use them later. So you get pregnant, of those 4, 2 of them take, you have twins all as well. 2 years later, you want to have another baby, and you say, I still have 2 embryos. Let's thaw them out. Let's implant those, and that'll save a lot of money. So that is the frozen embryo situation. Let's say you decide you don't want any more kids, you're done. So what do you do with those frozen embryos? Those are your significant other's genetic material. Do you give them away, knowing that you want to have kids out there somewhere? Do you tell them to throw them away, knowing that you've disposed of something that could be a child that is essentially an embryo, or what do you do? So that's a really the definition of an ethical dilemma is that there's no right or wrong answer. There's no right answer, there's no wrong answer. It's just all gray. So that's kind of what we're dealing with here. And I will tell you, a few years ago, I was teaching. I remember I was teaching at the time it happened. Probably 5 years ago or less, there was a hospital in California. There was a big fertility clinic. Something happened to the duct system in the place, and all the freezers that were housing all these embryos went bad. Every one of them in the hospital was destroyed. They had thousands of frozen embryos in that hospital because it was a fertility clinic. And they were all destroyed because of something happened in wherever they kept them. The temperature went bad, or I don't know. So they were frozen and they thawed out, basically, inadvertently. And they lost every single one of them. They had so many lawsuits that they had to shut down because people were dependent on they paid thousands of dollars to have those harvested, and now they're all gone. So anyway, the question is, what do you do with your frozen embryo? You don't want them. Do you give them away? Do you destroy them? What happens to them? Whether to tell the child later in life when that should happen. So do you tell your child that he's a result of a sperm bank, that his dad was from a sperm bank? If you do, what do you tell him? My neighbor she was remarried, but she had a child earlier and got from a sperm bank. She just went and got from a sperm bank, a sperm cycle sample, went and had artificial insemination, got pregnant, was single, and that kid was from a sperm bank. And he had a very difficult time with that. He was my son's age. He had a very difficult time with that. He just, felt like he had no dad, I guess, so to speak, and no connection. His mom was remarried. She had more kids by her new husband. So it was very difficult for him. Risk of long-term medications such as ovarian cancer and ovulation-inducing drugs. Again, we certainly increase a woman's risk of ovarian cancer when we use those ovulation-inducing drugs. So those are some specific ethical dilemmas that come from as a result of doing all this fertility treatment that we have to think about. Okay. Any questions about infertility? Because we're going to completely switch gears now and talk about contraception. The opposite. Complete opposite. Questions about that? So I think we spent a good bit of time talking about infertility, but I don't want you to, kill yourself studying for that. I think that you need some kind of introduction or base to it. There probably won't be more than 3 or 4 questions max from this material. Because, like I said, I want you to be exposed to it. But unless you work in a fertility clinic, it's not something you're going to see a ton of. You might see it in OB, but other than that, you can see it off the much. But certainly look over the things I said you need to know or need to know. Erectile dysfunction, that's a need to know. I mean, that has to do with fertility, but it also has to do with medical things as well. I mean, those are need to know things. Some of the other things if I said you need to know this, then look at that. But other than that, like I said, don't spend time worried about percentages of this and percentages of that, things like that. All right, contraception. Definition. Intentional prevention of pregnancy during intercourse. So you are, either preparing ahead or during intercourse using a method to intentionally prevent pregnancy from occurring. So contraceptives there's a wide variety available. There's actually 4 classes of contraceptives. And what we're going to suggest to a patient is going to be, really based on their situation. So what I will probably ask you is, here's a patient. Here's the description of their situation. Which contraceptive type would you recommend for them? We're going to talk about each type, and then you're going to have to make a judgment about what would be best for them. Because this would be something that the nurse would do. The doctor may prescribe something, but the nurse is going to be the one to say, this would probably be best for this patient. It's really going to be the one making that judgment. So things that we would consider when we recommend contraception: how old is the patient? Their general health level, their religious preferences. Obviously, if someone doesn't believe in using birth control, don't prescribe them oral contraceptives. That's silly, because they're not going to take them. The need for long or short-term contraception. Do you need to not get pregnant in the next 6 months, or do you need to want to not get pregnant in the next 6 years? That makes a difference in what we're going to give you. The likelihood of patient compliance. If you're dealing with an adult woman with Down syndrome, you're going to give her the pill and tell her to take the pill at the same time every day? That's not going to be effective. Not going to do that. What are the risks of undesired pregnancy for the patient? If this is a 25-year-old girl waiting on a heart transplant, we've got some big reasons for her not to get pregnant. So the risks of undesired pregnancy are significant for her, right? So we better not let her get pregnant. Ability to comprehend and follow directions. Again, if the patient is not fully competent, you've got to think about that and what you recommend. Okay, so 4 categories. Number 1, natural. I don't know why your textbook has this in there. Coitus interruptus, withdrawal. That is not birth control. So just for anybody who would like to know that, it is not a form of birth control, but it is listed as such because I'm sure it's probably used more often than we realize. But I would not call that a method of birth control. So I just put there because your textbook lists it. Fertility awareness methods. And that basically is learning your body's system and avoiding intercourse when you believe that you are fertile. So a lot of people with religious beliefs will use this method of birth control. They will try to avoid intercourse when they believe they are fertile. And that can be effective if you are very regular as a female, if your periods are very regular, it can be effective, and if you are very diligent, and if you have a partner who's also on board. So if it turns out that because of your cycle you have to avoid intercourse for 11 days out of every month, and your partner says, no way, you have a problem. That's not going to be effective. He's not happy, that doesn't make, he's not okay with that, there's going to be an issue. So it's really going to be, this is going to have to require motivation on the part of both partners, and it's going to have to be, you're going to have regular periods to be able to determine when you are likely to ovulate. So there are several different ways to do this, but basically it boils down to abstinence during fertile periods. So we may use the basal body temperature method. We may use the rhythm method, which is just like, again, fertility awareness. You learn that over 6 months, your cycles are anywhere between 14 and 18 days. Then you're going to ovulate somewhere between, I'm sorry, not 14 and 18. I meant ovulate. Your cycles are anywhere from 28 to 32 days is what I meant to say, which means you're going to ovulate on days 14 to 18, right? So that means you have to avoid intercourse from day 11 to day 21. So that's 10 days out of every 28 to 30 days that you have to avoid intercourse. So is that going to work? Is that going to work for you as a couple? Breastfeeding. There is such a thing as lactational amenorrhea, which means when you're lactating, you don't have periods because you're not ovulating. That is true up until a point. However, ovulation returns before your period does. So you don't have a period until you've already ovulated. So the first time you ovulate, you don't know. So there have been many babies that are born of women who are breastfeeding, especially as the baby gets older. I would say if you're exclusively breastfeeding, your baby's not getting anything else but breast milk. For the first 6 to 8 months of life, you're pretty safe. But after that, when the baby starts eating other foods, those levels start to drop because the baby's not nursing as much, and your ovulation will return at some point. In developing countries, you may notice that pregnancies are normally spaced at about 18 months to 2 years. If you look in a developing country that does not have access to birth control, they don't have babies 10 months apart. None of them do. Only we in the United States do dumb stuff like that. Because we're not, a lot of us are not breastfeeding, and so if they're breastfeeding over there, they're exclusively breastfeeding, that's all the baby gets, you are not going to ovulate for probably a year and a half after the baby's born if your baby is getting exclusively breast milk. But here in this country, we bottle feed or we feed our baby food very early, and so the baby doesn't nurse as much, and then our fertility returns much sooner. So that's natural. Anything that's a natural method of birth control is really just figuring out a way to avoid getting pregnant by not having intercourse when you think you're going to be fertile. That's the bottom line there. Barrier methods. Barrier methods are a way to prevent the sperm from getting to the egg, keeping them separated. So you can have intercourse, but you got to keep that sperm and the egg away from each other. How do we do that? Number 1, spermicides. Spermicides in and of itself, it's a foam or a spray that's supposed to kill sperm. It is not adequate in and of itself ever. It should be used with something, like a condom and spermicide, or a cervical cap or sponge and spermicide, but it should never be used by itself. It's an added benefit, not a on your own type of birth control. Condoms. Condoms are very reliable if used correctly. They have about an 86% success rate if they're used correctly. They do have disadvantages, of course. They're not perfect. They can break. Things can happen. The one thing about condoms that other methods of birth control don't have is that it protects protection against STIs. So if you use a condom, obviously as a male, you're not going to, well, protect those ways. You're not going to, contract an STI. So condoms are barrier methods. Cervical cap or sponge, used by the female, is a little sponge that's placed over the cervix before intercourse and removed a few hours after intercourse. It's disposable, thrown away after each use. There's a small risk of something called toxic shock syndrome with that. You guys know what toxic shock syndrome is? It is a staph infection, basically, that can lead to sepsis in a female. There was a huge run of toxic shock syndrome back in the 80s when these super absorbent, super duper tampons came out, and they were so absorbent that what they did is they absorbed all the liquid all the moisture from the mucosa in the vagina, which is, mucosa is supposed to be moist, right? It pulls so much liquid out of it that it causes it to dry out, and then when the mucous membranes dry out, what do? They crack and they bleed, and so then you have staph on your hands, and your hands have staph on it, tampon out, get staph in there, and then it can lead to sepsis because it gets in through those cracks in the mucosa. So we had a lot of females die back in the 80s from toxic shock syndrome until we figure out what was causing it. So anything that causes mucous membranes to dry out can slightly increase your risk of toxic shock syndrome because it's the absorbent. It absorbs fluid and liquid from the mucosa. It's a small risk. Diaphragm. A diaphragm is not a throwaway thing. It's permanent, used by a female. It's used with spermicide. Female must be fitted for it by a physician. If you have a baby or lose or gain weight, you have to be refitted for a different one. It's, again, placed over the cervix by the female before intercourse, left in for a few hours, and then taken out, washed, used rubber, and it's used over and over again. These are all barrier methods. Okay. The next thing we're going to talk about is hormonal methods. Hormonal methods, oral contraceptives, are the ones we think about the most, the pill. What happens with hormonal method of contraception is it inhibits ovulation. You need to know that. All hormonal methods of birth control inhibit ovulation, suppress ovulation, stop ovulation. So how do you not get pregnant using hormonal birth control? You don't ovulate. It keeps you from releasing an egg. So that's how it works. So for people that have religious beliefs, and I don't know what all religions have. I'm not Catholic, but I do know that there are some Catholics who believe that this is, against the teaching of the church and that they do not believe in hormonal birth control because, you're suppressing something that, is supposed to happen in the body. So this would not be, for some people with some religious preferences, they would not use this. So the most common thing we think of with hormonal methods are oral contraceptives or the pill. And it's a combination of estrogen and progestin, and as I said, it inhibits ovulation. Contraindications to the pill. History, if a patient has a history of DVT, if they have cardiac disease, coronary artery disease, breast cancer, if they have estrogen-dependent tumors, which means they're fed by estrogen and we're going to give them estrogen, it would not be good. Obviously, if you're already pregnant, we don't want you on the pill. If you're breastfeeding, we don't want you on the pill. If you're smoking and you're over 35 years old, you're not a candidate. If you smoke and you're over 35, you don't get the pill. It is a no-no. The risk of blood loss is too high. If you already have hypertension, and again, from prolonged immobilization. So you're in a car wreck and you break your pelvis. You're going to be on bed rest for 10 weeks. So you cannot then take oral contraceptives. Let's hope you don't need them. If you're on bed rest with a broken pelvis, let's hope you don't need them for 10 weeks. But anyway, so why do we take you off of those birth control pills? Because since you have prolonged immobilization.
You're immobile, you're already at risk for blood clots.
You're already at risk for blood clots. The immobilization, and you've probably learned in the second semester as well, when you break a big bone, that puts you at blood clots in and of itself. You break any big bone in the body, the large bone, the femur, the pelvis, hip fractures, things like that, just that puts you at risk of blood clots. Now we put you immobile for 10 weeks, that puts you more at blood clots. So we know that the pill increases your risk of blood clots. So now we're just like, it's just too much. So no hormonal contraceptives. Now, we also know effectiveness of the pill is decreased. This is important if taken with the following meds: some barbiturates, topamate, antifungals, anti-TB drugs. Y'all think this was on your test last week, wasn't it? About that rifampicin, is that how you say that? HIV protease inhibitors, all will lower the effect of oral contraceptives and most antibiotics. I'm not even going to give you the list because there are so many. Any patient on antibiotics should be told, do not rely on your birth control this month. You're on antibiotics, use another form of birth control while you're on antibiotics. That should always be told to patients, and any of these other drugs as well. So that is a specific medication nursing implication. Remember I said what's important about medications is why am I giving it and what are the nursing implications. These are nursing implications, right? Okay, so I'll come back to this 20 days of pills in just a minute, but we can have the pill, or we can have a transdermal system where you use a patch, a hormonal patch for birth control. It releases a little bit a day. There's a vaginal contraceptive ring that's put in for 3 weeks and taken out for a week. Same net effect, it's just instead of taking a pill, it's a vaginal ring, but it has to be put in for 3 weeks and taken out for 1. So how these work is this. How the pill works is this. The most commonly known form of hormonal birth control. We have a pill pack right here. As you can see, there are 21 blue pills and 7 green pills usually, or different color pills. So for that 21 days, the blue pill is the pill with the medication. So usually the Sunday after you start your period, I think that's usually the advice, you'll start that blue pill. You'll take it for 21 days. When you get to the end of the blue pills, then you start taking the green pills. The green pills are placebo. They're sugar pills. They're nothing. But the reason we give those is so you don't forget. I mean, if I had to remember, okay, take a pill for 21 days, don't take it for 7 days, it's too much risk of failure. So we give you sugar pills for another 7 days so you don't forget. So if you don't take them, it's not going to hurt anything. But for people who need to take a pill every day to remember, that works. So what happens then is you're not ovulating. When you're on the pill, you don't ovulate. But when we withdraw that medication for that 7 days, when you take the sugar pill, it will cause you to have what we call withdrawal bleeding. So you'll have what appears to be a lighter than normal period, but a period. It's really not a period because you didn't ovulate. But the belief is we don't want the endometrium to continue to build up and build up and build up and never shed away. Remember when I told you what the endometrium is? It's, if you don't get pregnant, it builds up for the baby, to support the pregnancy. And so if you don't ovulate, that buildup continues and continues and continues. So the belief has always been that you need to shed some of that endometrial tissue. So if we take you off of that pill, the medication, for 7 days, you have a little bit of withdrawal bleeding, you lose some of that endometrium as well. Now, there are some doctors who now say that's not necessary. You don't have to take the sugar pill. You can take those pills for 6 months straight if you want. It's fine. There's some controversy about this. Some docs think it's fine. Some docs think it's not okay. But we do still give the 21-day pill, 7-day placebo. That is still the standard way of doing the medication. Now, let's say you're getting married and you want to go on a honeymoon and you want to make sure you're not on your period during your honeymoon. You just keep taking the pill straight through. So you can do that for a month or two to kind of control when your period occurs. So that actually does work. So just don't, if you happen to be getting ready to go somewhere, get married, you don't want to be dealing with that. You just don't take the placebo. Continue to take the pills all the way through till you get back, and then you can kind of control your cycles a little bit with that. So that's kind of off topic, but it does certainly work. But the key is 21 days of medication, estrogen or progestin, 7 days off that causes some withdrawal bleeding. Most people will say it's a period. It's not because you didn't ovulate. Okay, questions about that? There's other different kinds of hormone contraceptives. Again, there's a progestin-only pill that has no estrogen. It's called the mini pill. Works basically the same, but this can be used with women who are lactating. It's the only pill that's safe for women who are lactating. There's a Depo-Provera injection, which also works to prevent ovulation. Most of you all familiar with this. It's a shot that's given about every 3 months approximately, an IM injection. It's administered during the first 5 days of menses, and then it's effective for 3 months. You want to be careful not to massage the site after you give the shot because It will increase the absorption of the drug. It's a sustained release absorption. You rub it, it'll make it be absorbed faster, and it'll make it not work as long. It will shorten the effectiveness of the injection.
Can't Depo-Provera also be used on men for chemical castration?
I don't know. Maybe. I've never heard that before.
Yeah.
Never heard that.
We
Oh.
use it on
You do?
patients that have sexual,
That's interesting. I
Issues,
didn't know that.
yeah.
Okay. Something I didn't know. Here you go. Learn something new every day. Implantable progestin, again, it's something that you're going to implant under the skin. It's a little tiny stick, and that can stay in for a longer period of time. Emergency contraception. Have you all heard of Plan B or the morning after pill? All that is, it's about the equivalent of about 4 or 5 birth control pills. What's in about 4 pills. So it's a estrogen progesterone in a large dose. So, you take 1 pill every day, it's about 4 pills. So if you're on the pill and you needed Plan B or morning after pill, you just take about 3, you can ask the pharmacist how many, I think it's about 4. Or you just take them all at one time, and it will be effective for the morning after pill. How that Plan B or morning after pill works is, if a pregnancy occurs, if a conception occurs, it prevents implantation in the uterus. So let's say a woman comes to the ER, she's not on hormonal contraception. If you're already on the pill, you shouldn't need it. But let's say you're not on the pill and you are sexually assaulted and you're concerned about pregnancy. So you come to the ER, report the assault, and you ask them about it. They give you the Plan B. They give you a pill or a number of pills that's about the equivalent of birth control pills, and you take it. And if the sperm and the egg were united, it will prevent implantation in the uterus. So you never will know whether you're pregnant or not. The one thing about it is it causes a lot of nausea and vomiting. How many of you all have been on the pill and you forget and you take 2 later, or God forbid you take 3 later? You're so sick. Yeah, you'll vomit all day. It's the same thing. It's the same net effect, basically. Yeah. And then last, an IUD, intrauterine device. This is a little device. There's pictures of it in your textbook. It has a tiny little string in the bottom, so you can make sure it's still there. It's implanted in the uterus, and there are 2 different types. There's one type that releases a hormone, and there's another type that's copper. If the copper ones destroy the endometrium, and they also can work as a spermicide, but that's not enough on its own. It destroys the endometrial layer, the copper does. Then there's another type that actually releases a hormone as well. That's the Mirena one. So there's 2 types. These things can be left in 5 to 10 years. So these are for people that do not want to have a baby for a long, long time, if ever. Maybe a 25-year-old woman says, I never want kids. She's not quite ready to have sterilization, but she says she doesn't want kids. This would be a great choice for her. She doesn't have to worry about it for 5 to 10 years, and then she can decide. She changes her mind. You can always just take it out. You can take it out in a medical procedure. Now, if you find out you're pregnant, it has to be taken out immediately. It can be dangerous if it's left in during pregnancy. So if someone would be pregnant, you really shouldn't be, but if you would find out you're pregnant, it has to be taken out right away. So there are 2 types. One is copper, one releases hormone. These are long term. So if you say, I don't want to get pregnant for 6 months, this is not a person who needs an IUD. I mean, it's a big procedure to put it in, it's a procedure to take it out. So an IUD is for somebody that needs long-term birth control, but maybe not permanent birth control. Permanent birth control now is sterilization, either male or female. I see that I changed my design on the slide. I see some of it's been cut off a little bit. Sorry about that. So sterilization is designed to be permanent. So we need to teach our patients this is permanent. Now I hear people say, oh, they use those clips now, so you want to have it reversed later. You should never consider a sterilization if you think that you might have it reversed later, because even the clips that they put on the fallopian tubes will cause enough scarring that it's usually permanent. So for the male, we do a vasectomy, which is cutting of the vas deferens, which is part of the tubal system that interrupts the transportation of sperm throughout the tract of the body. And basically, the sperm are the only things missing. There's still fluid, there's still semen. Sexual function does not change. The male cannot tell any difference. There are just no sperm in the sample. Now, once you do a vasectomy, you're supposed to go back within 6 weeks to have a sperm sample to make sure your sperm count is 0, because there's theoretically they could cut the wrong thing. They could cut a ligament or cut something by mistake. Usually with males they don't do that. Usually it's the right thing, but you want to make sure that the sperm count is 0 to assure that it has truly been effective. Now, for females, it's a tubal ligation or tubal occlusion. So what we're basically done is we're either cutting out a piece of each fallopian tube, or we're putting a clamp in so that it's smashed. And again, if we smash that tube with the clamp, yeah, you can take the clamp off, but there's enough scar tissue that usually it's still, they're damaged. Now, I've seen a few times in my life, where we've had people that come back after 2 years after having their tubes tied. You probably all heard stories of people have their tubes tied, 2 years later they're pregnant. And usually what happens is they cut a little piece out. The old-fashioned way of doing it was cutting a little piece out of the tube and then suturing each end closed. And what happens is, if you have your tubes tied right after you have a baby, you've got lots and lots of edema in your pelvis, very edematous. So the failure rate's a little higher if you do a postpartum sterilization. Because again, the whole pelvis is full of blood, full of fluid, and very edematous. So they put the suture on that tube, cut a little piece out of the middle, and then all the swelling goes down, and the suture gets loose and comes off. And there have been cases, I saw it with my own eyes, I wouldn't believe it, where the tube literally reanastomosed itself together. We did a case years ago where the woman said she had her tube tied 2 years earlier, and we could see where the tube had very crookedly reanastomosed itself back together. And she had a baby to prove it. So it can happen. The failure rate's pretty low. 6 to 8 out of 1,000 if you do your sterilization postpartum, 1 to 2 out of 1,000 if it's not related to pregnancy. Now, that's still less than 1% any way you look at it. Still very low. The recovery is for the surgery is much easier for a male than a female. For a female, because we're going in the peritoneum, it's considered to be abdominal surgery, even though it's a very small incision. And both must be considered to be permanent. So don't ever think on well, you better have some cash handy, and even if you do have cash handy, it may or may not work. It's easier, but it doesn't necessarily mean it will be effective. Because again, if you cut the vas deferens, there's still going to be scar tissue. You still can't guarantee it will take. But and it's very expensive, and insurance is not going to pay for it. So we certainly don't want to say, oh, I'll just have it reversed. Because even if you were wealthy and could do it, depending on how you scar, your body scars, it may or may not work. So those are the 4 methods of birth control: natural, barrier, hormonal, and permanent. So if I said to you, okay, I've got a 25-year-old, I mentioned this a few minutes ago, I've got a 25-year-old female who's waiting for a heart transplant, and she wants birth control. What do you think would be the best type of birth control to offer her of what we talked about? She's 25, she's waiting on a heart transplant, and she's got cardiac issues, and we absolutely do not want her to get permanent. She's 25.
An IUD. Or Depo.
Depo is it's hormonal, so we want to, because of blood clots, we stay away from anything hormonal because of blood clots. So I would say an IUD. That'd be the best choice. What if it's a 20-year-old little girl that has Down syndrome that does not live at home with her family? She lives in a home where there are male and female clients, and she's 20 years old and she has Down syndrome. She's verbal, but she's, certainly not capable of making birth control decisions. What would you recommend for her?
That's
An IUD.
It can be. But if you were making a recommendation, what would you say?
An IUD.
Depending on the family situation, sterilization is one thing that comes to my mind, because there's never going to be a time that she probably would be a good candidate for pregnancy. Now, that's where the controversy, that's more where the ethical part comes in. And her family would have to make that decision. A lot of family members with girls with Down syndrome or with other types of mental disabilities will do a sterilization. And that, again, is gonna require, probably some legal things like that. But if it were my daughter, that's what I would say for de-sterilization. But outside of that, I would say an IUD again, because a definitely shot, somebody's gonna have to take her if it's runs to get it. Who's gonna take her to get that shot? She's gonna get it. Hormonal birth control again, again, it's gonna be a monthly thing. So probably an IUD if you don't do something permanent. So I'm gonna ask you things like that. I'm gonna maybe give you an example of a type of a person. What would you recommend for that person?
Well, what I was thinking about with a heart patient was she's going to be on medications for the rest of her life. That could be teratogenic.
She is. And a pregnancy would be, and we're going to talk about that when we talk about cardiac effects in the body, but it can be done. I mean, I get what you're saying. She's going to have a major change in her medication, but we do have women who have transplants that have babies, so it can be done. So, for the most part, a good long-term thing like an IUD would probably be the best choice for her until, and we never know what kind of new things may come out that may make a pregnancy even better or easier. Then the last slide, it'll let you take like it's got a half an hour, it'll take like a 3-minute stretch break if I ready to need it. We'll try to get through as much of chapter 6 as we can. I'm just going to say this about abortion. And by abortion now, in the term abortion, I want to make clear, the term abortion means the termination of a pregnancy before 20 weeks. Just the word abortion itself doesn't mean elective or doesn't mean non-elective. It just means the end of a pregnancy before 20 weeks. So when you that GT-PAL, the A for abortion can be a miscarriage or it can be an elective abortion. So make sure to remember that the problem is when we talk about that GT-PAL, if you say it in front of your patient, they often come to offend and say, I haven't had an abortion. And they don't realize that when we say abortion, we mean either a spontaneous miscarriage or the voluntary end of a pregnancy. Any pregnancy that lasts shorter than 20 weeks is an abortion. That's the definition. So it may be spontaneous, it may be voluntary. For right now, we're going to talk a little bit about a voluntary elective procedure. So the woman desires an abortion. She wants to end the pregnancy. The majority of the time it's done in a surgical manner, which means you are removing the products of conception via dilatation and evacuation of the uterus. It can be therapeutic, which can be done for the health of the mom or baby, although that's not done as often as you might think. And then there's medical abortion as well. In the case of ectopic or tubal pregnancy, sometimes we'll give the mother methotrexate, which is a chemo drug, which will cause the pregnancy to not survive. And that's another method. So it can be medical via medication, it can be surgical via empty in the uterus. Either way, and therapeutic can be done for the health of the mom or baby. For example, if you work in labor and delivery, unfortunately, you may have a mom who has a baby with spina bifida and she decides she wants to terminate that pregnancy. And, if it's later in pregnancy, she may be actually on labor and delivery. She may have to actually labor if it's late enough in pregnancy. If it's early in pregnancy, then that's when you're going to have it done maybe in an outpatient setting or an abortion clinic. That has to be very early, like earlier than 12 weeks. So that kind of procedure to be done. Now, whatever your feelings are about abortion as a nurse, you're entitled to those. And I'm the first person to say you're entitled to your beliefs. However, I hope that all of you will understand that no matter what a patient has done or had, you will take care of them in the same manner. For example, you can be as pro-life as you want, but if you're caring for a patient who had an abortion, you should treat them like any other patient. If you work on a med-surg floor, you might take care of a prisoner who just may have murdered and raped somebody, and you don't refuse to take care of them. So why would you refuse to take care of a patient who has terminated a pregnancy? You don't. Now, if you don't feel comfortable assisting with an abortion, that's of course another color, and you don't have to do that. That means you don't go to work somewhere where they do abortions. If you don't feel comfortable doing pregnancy terminations, don't go to work at a surgery or somewhere where they do that. Ask before you take that job. Because, while you're entitled to this list and you do not have to assist, what good are you if you work somewhere where they do that all day long? You're not helping anybody. So you've got to think about where you're willing to work, what you're willing to do, what you're not willing to do in terms of that. And as I said, I hope that no matter where you work, if a patient has had an abortion, that you would treat them the same as you would treat any other patient. You should never treat them differently. As I said, I don't know any of you here that, if I said you have your patient's here from the prison and you raped a woman and killed her, you're still gonna take care of them, but you wouldn't take care of, but there are nurses who will say, she had abortion, I'm not gonna take care of her. That's horrible. And I hope that none of you will ever do that. So you need to be clear on what your beliefs are in terms of elective abortion. You are entitled to not participate in that procedure if that's what you believe, but you're not entitled not to take care of a patient who's had a certain procedure. That's done and over with. You didn't participate. You're just caring for this individual. And we treat them the same no matter what. We don't know when love. And you might be taking care of a man who raped and murdered somebody and you don't even know about it. So, you may not even be in jail and you might have got away with it. You don't know what's in anybody's past when you're taking care of them. You just take care of them because they're human beings. So you don't know what anybody that you've taken care of may have helped out. So don't hold that against any patient. Unfortunately, I have seen that be done, and it makes me very sad to see people refuse to take care of somebody because something they have done in the past. So, again, decide what your beliefs are, decide where you're going to work, and don't work, the best time. If somebody says not to work somewhere where they do those procedures. So that's really all I'm going to say about that. We just want to make it clear that an abortion definition is the end of a pregnancy before 20 weeks, whether it's elective or whether it's voluntary. Okay, take a 3-minute break, and then we're going to work on chapter 6. Just run to the bathroom if you need to, and we're going to start real quick.